Okay, this is the third series in this series of 3 videos on hypertension. This is on adult hypertension, and it explains a historical perspective of the pathophysiology of hypertension, which I think is a little novel and a little different to standard clinical awareness. Now, this work was done in both Wenzhou and Shanghai. I'm very grateful to Professors Wu Sheqing and Chengguo Rong in Shanghai, and to Professor Zhang Huijuan and Professor Huang Hefeng in Shanghai Jiaotong. And we're going to discuss injuries to vasomotor nerves in visceral arterioles in adult hypertension. This work was done in the pathology department, level 9 of the pathology block over here, and there's a little bit more to do, as you will come to see. Now, this work turns on a very important paper published in the American Journal of Pathology in 1937 by Alan Moritz and Mary R. Oldt in 1937. And what they did was look in great detail at 100 hypertensive subjects post-mortem. And what they found was that when they looked at all the different organs, they found particular narrowing of the arterioles in particular kidney, spleen, pancreas, and adrenals. They didn't have an explanation for this narrowing of the blood vessels, but it was very definite observation in histological terms, and they went to great lengths to confirm it. They took at least 8,000, looked at 8,000 blood vessels in the study, and the important conclusion that they came up with was that in hypertensive individuals, these visceral arterioles were significantly narrowed. Now here I'm illustrating a narrowed arteriole. The long white arrow describes the vessel diameter, and the shorter white arrow relates to the lumen diameter. In other words, the vessel wall here is thickened. And Moritz and Oldt came up with this magic number of 1.4. If the vessel to lumen diameter was less than 1.4, then you had a normal arteriole. If you had a vessel diameter to lumen diameter of more than 1.4, then that was abnormally thickened. And that holds up today, holds up across a lot of organs in a lot of situations in hypertensive subjects. So that was the key finding. Now, how did this abnormal arteriole and nerve come to being? Well, the evidence is largely in somatic studies, not in autonomic studies. But what we think happens is that there's an increased intravascular pressure in the lumen of the arteriole. The blood pressure increases, and that injures the very adjacent vasomotor nerve, or the nerve that controls the blood vessel. It gets popped, it gets injured, releases a lot of cytokines, and those are proteins which lead to regeneration of the injured nerves and to hyperplasia of the denervated vessel wall. So instead of a normal situation like this, you get this sort of situation where you have a thickened vessel wall surrounded by injured nerves. And if you look in longitudinal section, you get this sort of appearance. And so you have this release of cytokines that has 2 key effects. First of all, the proliferation of abnormal nerves at the site of the injury, and hyperplasia, or thickening of the denervated arterial wall, with narrowing of the lumen, which contributes to hypertension in these subjects. If you look around the body, as they did in kidney, spleen, pancreas, and adrenal, this shows the thickening of the arteriolar walls in all these subjects. This shows, the second column shows is staying for nerves, and that shows all these injured nerves here in brown. And here's loss of nerves in the pancreatic nerve bundle, often described as a cutting artifact, when in fact it's a pathophysiological finding of great significance. And then again in the adrenal cortex here, this showing background hyperplasia of the adrenal cortex, which is an explanation for this unusual condition of adrenal cortical hyperplasia, which appears to be derived from injuries to the adjacent nerves. We see the same in the uterus. This is in a non-pregnant uterus. This is in a pregnant uterus. Slightly different sort of setting, but again, the narrowed arteriole. And in the uterus in preeclampsia, we see this positive staining for a stretch receptor, which is absent in the kidney, spleen, pancreas, and adrenals. So we think there's something slightly different going on in terms of the uterus in preeclampsia. So that's all I want to say. This slide summarizes what I hope summarizes what we've been saying. It provides for we need to prevent the key events that lead to high intravascular pressures, and they're all features, I'm afraid, of 21st century living. But optimal treatment, it opens up different ranges of optimal treatment, which may include interrupting some of these processes. So adult hypertension, which is what we all, well, a lot of us die of in due course, which causes heart attacks and strokes and lots of different visceral vasomotor injuries, as I've just described. It has a similar pathophysiology to both fetal hypertension and pregnancy hypertension. Medicine somehow misplaced the emphasis on the autonomic nerves. It's important that we get back to some basic lifestyle causes of these important diseases. And hypertension, there's nothing more important than controlling your blood pressure as you get older. So I hope that's helpful. It's a brief summary that I hope I've raised some questions, always a little something different and a little something new. So thank you for listening. Until the next time, thank you very much.